أنا كده بدأت التسجيل خلاص يا دكتور ياسر.
بسم الله الرحمن الرحيم. Good evening, everyone. Welcome in this meeting, this special meeting of ESNT Zoom meetings. Tonight, we have one of elegant Egyptian speakers in the USA with an extremely marvelous topic that he is interested and he will present to us. Professor Elhusseini, Professor and Medical Director, Kentucky University, USA, will speak to us today about Adynamic bone disease. Welcome, Professor Amr. Professor Amr is well known by his interest in bone mineral density, CKD, PMD, and also has many researches in many aspects of nephrology, reaching more than 130 researches in all over aspects, especially bone mineral disease. He is also known with his CME activities everywhere, especially in Egypt. He shared us many times here in the Zoom meetings, speaking about bone mineral density, and shared many Egyptian universities and his mother university in Mansoura University in many activities, and the last was about a few weeks ago. He is one of our stars in USA, which we all are proud of. And we are so lucky today to hear from him his special lecture about Adynamic bone disease. Welcome again, Professor Amr, and please share your slides and stuff.
Thank you so much. Can you see my presentation?
Unfortunately, no.
Yes, Dr. Amr, you can move the slides.
أنا مش.
What do you see now?
Desktop.
So you see a picture for Dr. Hussein, right?
Yes, yes, in the desktop.
And you see my presentation now, right?
No, still not.
Still no.
Do you see it now?
Yes. Can you make change to this slide?
Yeah. You see the progress
Okay.
of my slides?
Yes, yes, okay, yes.
Very good. Thank you, Dr. Yasser, for this nice introduction. I really am proud and happy to be with you today. This is my home. I practiced nephrology in Egypt before I moved to USA. And, you know, all of you either are my professor, my colleagues, or my students. So I'm very happy to be with you today. I'm going to talk about a challenging diagnosis. We are all struggle to diagnose and to treat Adynamic bone disease. And we all need to be better in diagnosis and management of this disorder. First of all, I think I have to say that I didn't have any disclosure. I'm not part of any pharmaceutical studies, or I'm not getting any money or support from any of the pharmaceutical companies when it comes to the bone disease or Adynamic bone disease. I'm part of some multi-center randomized controlled trial, but none of these trials are related to bone or management of CKD-MBD. I'm going today to talk about the definition of Adynamic bone disease, the magnitude of the problem, how can we diagnose Adynamic bone disease, and we'll talk about basic and advanced management of Adynamic bone disease. So Adynamic bone disease is one variety of renal osteodystrophy. We know that we have several varieties of renal osteodystrophy, but one of the most common ROD, we call it ROD, renal osteodystrophy variety, is the Adynamic bone disease. To diagnose Adynamic bone disease, you need bone biopsy. However, there is non-invasive technique that can give you very good certainty with very good positive predictive value and specificity to diagnose bone disease, adynamic bone disease non-invasively. But with the histopathology, you can diagnose adynamic bone disease if you see the osteoblast and osteoclast numbers are low, and the bone turnover is low, and also the bone volume is low, and the bone would be over-mineralized bone because it's old bone, so you don't see too much of the osteoid because all will be calcified, will be mineralized, so the bone will be over-mineralized, and you don't see accumulation of the osteoid. So this means that adynamic bone disease is a low turnover bone disease without evidence of osteomalacia, and I'm going to explain it to you just in a little bit. But you see the patterns of ROD, the renal osteodystrophy. If you have, here is the adynamic bone disease. Adynamic bone disease, you see the bone turnover is low. There is mineralization, normal mineralization rate, so there is no mineralization defect. And at the same time, the bone volume is low. This is contrary to osteitis fibrosa or severe high turnover bone disease or hyperparathyroid bone disease, when you see that the mineralization is normal, but the turnover is very high and the bone volume is high. Here is the bone volume is low, turnover is low, but there is no mineralization defect. The mineralization defect, you can see it here in osteitis and the osteomalacia. When you see the turnover is low, bone volume might be low or normal or high, but the distinguishing feature is the mineralization defect with accumulation of osteoid. Might be a little bit complicated, but I will explain it to you here with the histopathology. So here is the bone. This is a very good example of hyperparathyroid bone disease or osteitis fibrosa cystica or high turnover bone disease. When you see the bone is hypercellular, these are osteoblasts. So there is a lot of osteoblasts. There is a lot of multinucleated giant cells. These are the osteoclasts. So the osteoclasts are eating up the bone and inducing this bone resorption bed. Here is another smaller osteoclast. So these are bone resorption cells. And at the other side, you can see the osteoblasts are trying to form a bone. So both the osteoclasts are very active, the osteoblasts are very active. So the bone formation rate is high, but bone resorption is high. And you see here is the osteoid. So the osteoid is a protein, which is a collagen. It's a collagen type 1. It's a very tough kind of protein. And this is laid out by the osteoblast. So the osteoblast lays out this unmineralized bone, which is a collagen. Then after that, minerals come in, the calcium, phosphorus, and the hydroxyapatite, and mineralize this bone. And you see this mineralized bone with the blue color. And here is another cell called osteocyte. This is a mature osteoblast that get trapped inside the calcified or mineralized bone. These are a good example of osteitis fibrosa cystica, and you see in the bone marrow a lot of fibrosis, okay? So this is high turnover bone disease. The other spectrum that we are going to focus on today is this one, the upper right corner. This is the adynamic bone disease. So in the adynamic bone disease, first of all, the bone volume is very low. So here are adipocytes, right? But the bone is very low. You don't see osteoid. So this red color, you don't see the osteoid because there is no new bone formation. The old bone is already mineralized. So you just see the blue colored bone and it's acellular. You don't see, at least a lot of osteoblast or osteoclasts because the bone is very hypoactive. Here is the other spectrum of the disease, which we call osteomalacia. You see a lot of osteoids, so increased osteoid volume and osteoid thickness. Okay, this is osteomalacia. We don't see this very often in adults. We used to see it more in children with severe hypophosphatemia, hypophosphatemic rickets, hypocalcemia, severe vitamin D deficiencies in children, but we don't usually see it in adults, at least nowadays. And here is mixed, uremic osteodystrophy, when you see a lot of osteoclasts and osteoblasts, and at the same time, a lot of osteoid. So this is mixed uremic osteodystrophy. Today, we are going to talk and focus on the adynamic bone disease, this acellular or hypocellular or hypoactive bone. So you don't see, cells here except these osteocytes. You don't see osteoblasts, so the bone formation rate is very slow, and bone resorption is very slow. By the way, the first stage of bone formation is to have bone resorption. So if you don't have bone resorption, you don't form new bone. And because there is no osteoblast, there is no osteoid. So you just see the over-mineralized bone here. How we diagnose the adynamic bone disease, we said it's usually diagnosed by bone histology. And it's very misleading because it's very silent, quiet disease. It's frequently asymptomatic and needs a very good degree of suspicion. So if you don't suspect it, if you don't search for it, if you don't look for adynamic bone disease or low turnover bone disease, you're not going to diagnose it. So the two main keys for adynamic bone disease is to see the serum calcium level is a little bit on the higher side and the BTH is on the lower side. So BTH less than 150, especially in presence of mild hypercalcemia, is a key element in diagnosis. However, not all patients has mild hypercalcemia. A lot of patients with adynamic bone disease or low turnover bone disease have normal serum calcium, and BTH might be, more than 150. And I'm going to discuss with you these numbers just in a little bit. There is non-invasive bone turnover marker we can use, and of course, the definitive diagnosis is the bone biopsy, which is a minimally invasive technique. Here is the use of non-invasive, because we are not going to do bone biopsy for every single patient to diagnose adynamic bone disease. So there is a lot of biomarkers or bone turnover marker we can use. I gave a lecture in the Egyptian Society of Nephrology annual meeting, I think in June, 2 months ago, how to use these biomarkers. So I think it's beyond our scope today, but very, and just very quick, if you have BTH level less than 150, if you have total alkaline phosphatase also less than 150, and bone-specific alkaline phosphatase less than 20, it has very good predictive value and specificity for low turnover bone disease. If you have bone-specific alkaline phosphatase above 20 and the BTH above 200, this virtually exclude high turnover bone disease. There is a lot of studies. They want to replace the invasive bone biopsy with using new technologies, especially bone turnover biomarkers and high resolution peripheral quantitative CT, the HRBQ-CT. And here is this study was published about 3 years ago. They said bone biomarkers, which is bone-specific alkaline phosphatase, intact B1NB, TRAB5P as markers for bone formation and bone resorption, with the HRBQ-CT may have the potential to reduce the chances or the need for bone biopsy, and they may also be useful in selecting patients to treat for high or low turnover. So we all know about adynamic bone disease or low turnover bone disease. Is it an often and a common findings in our patient, or we are talking about something rare that we don't usually see in our patient? Here is, there is several studies I can show you. This is one of the most important studies. It was published in Kidney International 2008, when they did a bone biopsy for about 100 patients, and they tried to come up with the prevalence of different forms of ROD, renal osteodystrophy, according to the PTH level. You remember before 2009, we used to use the KDOQI, not the KDIGO guidelines. So the KDOQI guidelines, they said we need to keep the PTH, the intact PTH, between 150 and 300 nanogram per deciliter. But if you look to these patients within this range of PTH, within the target range, when they did bone biopsy for this patient, 64% of them had low turnover bone disease. So, even keeping your patient within the target level PTH of 150 to 300 doesn't prevent adynamic bone disease or low turnover bone disease. And actually 2/3 of these patients might have low turnover bone disease. On the other hand, if the PTH is less than 150 to our dialysis patient, 82% of them will have adynamic bone disease. Even keeping the PTH above 300 doesn't prevent adynamic bone disease. At least 1/3 of these patients had adynamic bone disease, and another 2/3 or less might have high turnover bone disease. By the way, you see normal turnover is very low. It's very rare to find the normal turnover, to find this balance in our dialysis patients. They have trends to be on low or high turnover sides. So very important, very common problem, very prevalent among our patients, especially with lower PTH level. If you keep the PTH below 300, you will increase the chance of having adynamic bone disease. This is the biggest bone histomorphometry study for dialysis patient, was published from our division about 10 years ago. And Maluk found in 630 bone biopsy patient in dialysis population, about 58% of them had low turnover bone disease, 18% had normal bone turnover, and 24 had high turnover. Of course, white population has higher prevalence of low turnover bone disease compared to blacks. Blacks, for some reason, they have higher high turnover bone disease, while white, they are at more risk to have low turnover bone disease. These two studies actually changed the KDOQI guideline to the KDIGO guideline, and now we are using the target PTH of 2 to 9 folds of normal, of the upper limit of normal. This means that instead of the previous guideline to keep the PTH between 150 to 300, the previous KDOQI guideline, now we are keeping the PTH between at least 150 to 500 or 600, according to your upper limit of normal of the PTH. Because even keeping the PTH, between 150 to 300, still we have high, prevalence of adynamic bone disease. So, these two studies changed the guideline for keeping PTH to a higher target compared to the old KDOQI guideline. And now we are just trying to, keep the phosphorus level toward the normal, not necessarily to be normal, and also to keep the calcium level within normal level. If you see the trend of using IV, the calcium mimetics, the oral calcium mimetics, and the IV vitamin D, you see about 70% of our dialysis population in America used to receive, vitamin D, active form of vitamin D, the IV form. And about 30% were receiving calcium mimetics. Of course, African American, they tend to get more vitamin D and more calcium mimetics to control their hyperparathyroid bone disease. But on average, about 70% till 2014 were receiving IV vitamin D on dialysis, and about 30% were receiving calcium mimetics. If you see the prevalence right now, you see that less patients are getting both IV vitamin D and calcium mimetic to avoid over suppressing the PTH and inducing Adynamic bone disease. So 2016, 58% were receiving IV vitamin D compared to 50% by the end of last year. And when it comes to calcium mimetics, also the use of calcium mimetics is going down from about 28% to 21%. Also, you see the serum calcium level. Now we are accepting more lower serum calcium level. In the past, we used to have about 10% of our patients with serum calcium level less than 8.4. Now it's up to 16%. So as long as the hypocalcemia is tolerable, asymptomatic, we don't have to increase, the calcium load and to induce more positive calcium balance, because this can induce more adynamic bone disease. And here is the BTH. Over time, you see that we are accepting higher BTH level, especially in African American. Now the trend, up to 500, 550, and in white population up to 400. This was in August 14. But you see here now we are accepting higher BTH level. If you see the BTH level more than 600, about 22% of our patient has BTH more than 600, and this is just about 8 months ago. And if you see BTH level less than 150, is going down from 13% to 10%, and I think we need also to see lower number of this to avoid low turnover bone disease. Why do we need to treat adynamic bone disease or low turnover bone disease? We all know about high turnover bone disease. It eats up the bone, it induces bone resorption. What about adynamic bone disease? Why do we need to treat it? And as you see here, when they divide the dialysis people to three tertiles according to their BTH, you see that patient with a BTH around the 300, they have the lowest fracture risk. And if you compare those to patient with less than 300 or more than 300, less than 300, the patient with lowest tertile of their BTH, they have 2.4 folds of fracture compared to only 1.6 fold greater risk of fracture for BTH more than 300. So the highest risk of fracture is in the patient who had the lowest BTH tertile. And you can see here also hip fracture, which is a major osteoporotic fracture. You see if the BTH is low, especially if it is less than 50, there is 4.1 in folds increased risk of hip fracture. Between 50 to 150 is still very high, 3.4. If you see BTH more than 800, only 3.4 folds is still high, but not as bad as if you have BTH on the lower level. And if you see the adjusted calcium, if the adjusted calcium is low, yes, you have higher increased risk of fracture. But if the adjusted calcium is high, you see 4 folds increase in the fracture risk. Combination of low BTH and high serum calcium put you on a higher risk of fracture, especially hip fracture. Another concern, so adynamic bone disease is not only bad for the bone, but also bad for the heart, and it might increase the cardiovascular calcification risk. So we all, talk about, calcium based, versus non-calcium based phosphate lowering agent. Is this going to increase the calcium load, the cardiovascular calcification? And the answer is easy. If you give higher calcium load, higher calcium containing phosphate binder to patients with adynamic bone disease, certainly you will see increased calcification risk. Here you see the aortic calcification is barely, increasing with the increased dose of calcium containing phosphate binder. And if you do this to patients with active bone, especially with high turnover bone disease, the bone can use the extra, the excess amount of calcium. So this shouldn't be a problem, but the problem usually happens that you will see more calcium calcification and positive calcium balance in patients with adynamic bone disease and low turnover bone disease. You need to remember that 99% of our calcium goes to the bone. If the bone is dead, if the bone is very hypoactive, this calcium doesn't go to the bone and it doesn't actually stay in the blood, and it goes to the microvascular and the macrovascular, eventually then induce more cardiovascular calcification and mortality. We, I think, all know about this. If you have BTH between 150 to 300, you are at the lowest risk of mortality. If the BTH goes up, mortality goes up. But if the BTH goes down, actually, it's very steep relationship. The mortality rate goes higher, and the relation between lower BTH level and increased mortality is very strong. So let's focus now on which patient get adynamic bone disease. What is the risk factor that we need to avoid for to decrease the chance of adynamic bone disease or low turnover bone disease? First of all, we talked about BTH. We need to keep the BTH between 150 to 500 to avoid the risk of adynamic bone disease. Is this enough or not? Probably this is not enough by itself, but at least this is the key. We said we need to decrease the calcium balance and the calcium intake, so decrease the calcium load and the calcium in dialysis. So patients who are getting more calcium, especially in dialysis and also in calcium containing phosphate lowering agents, are at increased risk of adynamic bone disease. Patients who are getting more vitamin D analogs, you remember vitamin D analogs doesn't only suppress the BTH, but increase calcium balance and increase also phosphorus balance. So both the patient on a higher risk of adynamic bone disease. Older population tend to have more hypoactive bone compared to young population. Diabetic patients are at higher risk of having low turnover bone disease. Patients with hypogonadism, especially postmenopausal osteoporotic patients, BD patient, because patient on peritoneal dialysis, you get more calcium through the peritoneal dialysis fluid compared to the hemodialysis. Aluminum overload can induce osteomalacia and adynamic bone disease. We just diagnosed the patient actually from Egypt with aluminum intoxication, and aluminum induced the bone disease and osteomalacia. And we thought that we don't see this anymore, but actually when we did bone biopsy, we find it's still there. So we have to be, very careful, especially you check your aluminum level and the RO, make sure that the RO and deionizer are working okay, and you check the serum level at least once or twice a year of your patient. And if needed, you need to do bone biopsy to avoid, to make sure that you don't have aluminum intoxication in your patient. Use of anti-resorptive therapies, especially bisphosphonates, which is very long-acting, can suppress the bone for a long time. Use of steroids, especially in kidney transplant patients and patients with who are receiving steroids for a long time because of GN or nephrotic syndrome. But the severest form of low turnover bone disease and adynamic bone disease, we see it actually after parathyroidectomy. So please don't do many parathyroidectomy. You have to be very wise. And if you need to do parathyroidectomy, if this is the last resort, you need to be gentle. You need to tell your surgeon that we need to keep the BTH above 150 because they are also, very scared and they are afraid from failure of technique. So they think that to be successful, they have to take out as much parathyroid tissue as they can, and they keep the patient with 2 digits of BTH level. So you see most of the patient will left with BTH, very small amount of parathyroid tissue, and the BTH will stay in more than 80% of the population up, below 150. This study actually we published 3 years ago, and we examined all of our patients who had parathyroidectomy, and we discovered that, our surgeons are usually very aggressive in taking out, our BTH, parathyroid gland tissue, and they end the, they just flip the coin and they change the spectrum of the hyperparathyroid bone disease to hypoparathyroid bone disease and adynamic bone disease. And actually, this can induce hypocalcemia, and these patients are usually getting more calcium to replace the hypocalcemia. And because there is no BTH, or the BTH is very low, the BTH, this calcium doesn't stay in the blood, and whatever calcium you're giving them, it doesn't go to the bone because the bone is very hypoactive, and also it doesn't stay in the blood because the BTH is low. But what happens is it goes to the cardiovascular system and increase cardiovascular calcification. This is very important study that they did bone biopsy before the parathyroidectomy, and they repeated in a year. And also they did cardiovascular calcification by multi-slice CT scan. And when you see what happened to this patient after they took out the parathyroid gland, you see they changed the spectrum from high turnover bone disease, and all of them to 90% of the patient end up by having adynamic bone disease, and 80% of them had very low turnover bone disease. So it's very important. And also they found that the shift from high turnover bone disease to low turnover bone disease was barrier to the increased cardiovascular calcification risk. So be very vigilant and try to talk to your surgeon. If you need to do parathyroidectomy, try to avoid hypoparathyroidism and low turnover bone disease and adynamic bone disease. Okay, let's focus now on the management of adynamic bone disease. And there is two levels of management. First is the basic, intervention that we can do. And the question is this basic management of dynamic bone disease is enough, or do we need to do more advanced, management of this adynamic bone disease? So we talked about the calcium load. So we can try to decrease the calcium load by giving less calcium in the dialysis, by changing calcium acetate or calcium-containing phosphate binder to non-calcium-containing phosphate binder, try to decrease the calcium intake, then stop the vitamin D receptor analog, the active form of vitamin D, and the calcium mimetics as well. And the question is, do we have an evidence to support that if we do these interventions, this basic intervention, is this going to help our bone? Is this going to improve our bone turnover? Is this enough? And how to follow the response to this intervention? Let's talk first about the evidence. Do we have evidence by, if we decrease the calcium in dialysate or change the calcium containing phosphate binder to non-calcium containing phosphate binder and decrease vitamin D analog and calcium mimetic, is this going to help our bone? Several studies have examined these hypotheses. And you see here, this is a randomized clinical trial in 51 peritoneal dialysis patients, and they did bone biopsy before and after the intervention. And the intervention was they randomized the patient to two groups, one with high calcium dialysis, 3.25 milliequivalent per liter, and the other group is with low dialysate calcium, 2 milliequivalent per liter. You see here, patients with lower calcium in the dialysate has, better BTH. The BTH was much higher, about 3-fold higher compared to patients with high calcium dialysate. And also you see the bone formation rate improved significantly in patients who are getting lower dialysate calcium. So lowering dialysate calcium reduced the serum calcium level, increased BTH about 3-fold, and normalized bone turnover. So this actually a very good intervention that you can do. Also, this was in the PD. What about the hemodialysis patient? This is another intervention study. And hemodialysis patient, they just categorize the patient to two groups: group with low dialysate calcium and group with high dialysate calcium, 1.25. This is actually milli equivalent, not millimole per deciliter. And you see patients who are getting more calcium in the dialysate, they have higher coronary artery calcification score at 12 and 14 months. And also at the same time, the adynamic bone disease decreased from about 85% to 41% in the lower calcium dialysate group. So very important, decreasing the dialysate calcium actually decrease the calcification scores and also improve the bone formation rate, trabecular thickness, and bone volume. So this intervention is good. So what about changing the calcium-containing phosphate binder to non-calcium-containing phosphate binder? Several studies had shown that giving less calcium, especially in patients with adynamic bone disease, will improve the BTH and also will decrease the chance of adynamic bone disease. So sevelamer improved the bone formation and trabecular architecture in patients with adynamic bone disease or low turnover bone disease. However, there was no significant change in the mineralization or the bone resorption. What about overuse of vitamin D and especially the active forms of vitamin D? So here is a study that was done in our division many years ago, and they compared, it's a randomized clinical trial, and it was double-blinded, and they compared the placebo to the 125 dihydroxy vitamin D administration, and the calcitriol decreased bone turnover and induced adynamic bone disease in 80% of patients. So it's very important not to overuse the vitamin D analogs and the vitamin D receptor agonists because they can induce adynamic bone disease. This is a very famous study, was published in Kidney International 2015. It's called Bonafide Study. They did bone biopsy before and after the cinacalcet in patients with high turnover bone disease, and 77 patients that were given the cinacalcet for 6 to 12 months, and the median BTH decreased from more than 900 to 480. By the way, the severe hyperbaria improved. And you can see here, adynamic bone disease didn't happen in the majority of patients. Only 2 patients had adynamic bone disease, and the majority of patients, they improved their severe high turnover bone disease without inducing the adynamic bone disease. So this is contrary to use of vitamin D analogs. It seems cinacalcet or calcium mimetic can inhibit bone resorption, but doesn't induce adynamic bone disease for some reason, because there is a lot of explanation, but it seems it has anabolic effect. So it prevents the adynamic bone disease from happening. Also, there is experimental evidence that calcium mimetics can maintain bone turnover despite it decrease the hyperparathyroid bone disease and the BTH, but doesn't induce low turnover bone disease. Then the question is this enough? If we decrease dialysate calcium, if we change the calcium-containing phosphate binder to non-calcium-containing phosphate binder, if we decrease the calcium load, and if we stop calcium mimetics and vitamin D analog, is this enough? Is this going to correct the bone or not? So, our target is to keep normal turnover, and normal turnover is as we discussed, is very high to achieve. And we are not going to do bone biopsy, for all of our patients and repeat it before and after this intervention. But you can also see the changes of bone turnover biomarker and the BTH. If the BTH before this intervention was 2-digit or was less than 150, and now it's 300, 400, or 500, you're very certain that this patient doesn't have low turnover bone disease, especially if you see the alkaline phosphatase is moving up, which is a marker of bone formation. If you can do the bone-specific alkaline phosphatase and you see the bone-specific alkaline phosphatase is more than 20, this actually excludes if the BTH is more than 200 and bone-specific alkaline phosphatase is more than 20, exclude adynamic bone disease. So you can check the response, see the serum calcium level is not high. you see the BTH is going up, the bone-specific alkaline phosphatase and other biomarkers are moving to the right direction. Is this enough? But you can do also other things like non-pharmacological approaches that can help. Weight-bearing exercise. Weight-bearing exercise is very important for bone formation because it suppresses chlorostin and it enhances the Wink pathway, so increase bone formation just with weight-bearing exercise. Physical therapy, asking the patient to be more active and ambulant will help. If you have a patient who is lazy or don't move, these inactivities will increase the chances of having low turnover bone disease. And if you have low turnover bone disease, you will have higher chance of fracture than if the patient fracture will be or she will be less active, and it's a vicious circle. So try to convince the patient to be more active, and instead of giving very expensive medicine, just doing physiological or natural things is very important. Balanced organic diet, especially the plant-based protein, is very important for the bone health. Stop smoking. Make sure the patient is not a smoker, and of course, we advise the patient here to avoid alcohol as well. Okay, if this is not enough, if you don't see the BTH moving to the right direction, if you don't see the serum calcium is normalized or going down, if you don't see the bone-specific alkaline phosphatase going up, so you're certain that this, basic intervention is not helping, and you might need to do more advanced intervention. We have several osteoanabolics, so medication that increase bone formation and helps to build up the bone. Teriparatide, which is 134 BTH, is one of them. Abaloparatide, which is a PTHRB, parathyroid hormone-related peptide, also is very good. Romosozumab is anti-sclerostin monoclonal antibody that can be very helpful, especially in postmenopausal osteoporosis. However, its use in CKD patient is a little bit challenging. In the next 5 minutes or so, I will just show you some studies that use the teriparatide, abaloparatide to improve bone health and to improve bone formation in patients with adynamic bone disease. Here is one study they used, even they treated hypercalcemia and adynamic bone disease with the teriparatide, and they did, this was published 2 years ago, and they did literature review, and you see most of these studies, they give teriparatide, which is usually the standard dose is 20 microgram sub-Q every day. Then you give it for a year. You don't give it for more than 2 years because there is a chance of increasing the osteosarcoma. So FDA, they don't recommend it for more than 2 years. In Europe, they can give it up to 3 years. And as you see here, there was only one study that did bone biopsy before and after, and they showed that there is increased mineralization, bone and bone volume and bone turnover. The rest showed that there is increase in the BMD and some of the biomarker. So, and also this study, they did the 3D micro CT reconstruction of bone biopsy before and after. And if you can see here, after giving 20 units of teriparatide for 21 months, you see that the cortical thickness is improving here. It's more thick, it's less porous, and you see the trabeculae that used to be a rod-like structure is now a plate-like structure, so the trabecular bone volume, connectivity, and the cortical thickness improved with teriparatide. There is other several studies, especially coming from Japan, when they give another dose of teriparatide, instead of daily sub-Q, they give weekly doses. Instead of giving 20 mics, they give 56.5 weekly doses. And as you see here, there is good changes in the lumbar spine BMD and the vertebral BMD for these patients after giving this dose of the teriparatide. Another study, they random the patient to receive either teriparatide or just for observation. And you can also see that the teriparatide improved the lumbar spine, BMD, and bone formation markers increased. Bone resorption marker did not change in the teriparatide. This means that they increased the bone formation, and this was reflected by improvement of the BMD. Abaloparatide is more recently used, and there is several studies that showed actually that abaloparatide is more effective in improvement of the BMD, and especially in post-menopausal osteoporotic women. You can see this study, very big study on more than a couple thousand of patients who were randomized to receive abaloparatide, placebo, or teriparatide, and you see, more improvement in the BMD and the total hip and the lumbar spine, the abaloparatide group, of course, compared to placebo, but also compared to teriparatide. So abaloparatide injection, daily injection is also very good to improve bone formation rate, especially in patients with low bone formation, adynamic bone disease, or low turnover bone disease. And this reflects with a decreased risk of fracture in the abaloparatide group compared to teriparatide or placebo group. And here you can see also improvement in bone-specific alkaline phosphatase and the B1, NP, and CTX. So this is a bone formation and bone resorption marker. With teriparatide, it has the best improvement in both. So it improved the bone formation and bone resorption. Then they did the post hoc analysis for this, thousands of people who received teriparatide, and they try to categorize the patient to 3 subgroups according to their kidney function with GFR less than 60 or 60 to 90 or above 90. And among all the 3 categories of the kidney function, even with CKD stage 3 with GFR less than 60, you still can get at least the same response. There was trend of better improvement in the lumbar spine and femur neck BMD in patients with lower kidney function. However, this was statistically not significant, but at least you can get the same effect, the same impact of using teriparatide in improvement BMD as patients with normal kidney function. Then the last osteoanabolic is the anti-sclerostin monoclonal antibody. And we know that sclerostin, it inhibits the Wnt signal and it inhibits maturation of osteoblasts. So increase of sclerostin, and actually sclerostin comes out from the osteocytes. And we give a lecture before that. There is the CKD, the chronic kidney disease, is a state of osteocyte dysfunction, and the osteocytes start to secrete more sclerostin. One of the problems that sclerostin can induce is to suppress bone formation because it prevents the maturation of pre-osteoblast to osteoblast, so it can induce low turnover bone disease, and the patient will have more increased risk of fracture with less bone volume. But on the other hand, actually, sclerostin has on the blood vessel, it can decrease calcification because it decreases the chance of transforming osteochondrocytes and osteochondrogenic transdifferentiation from the smooth muscle cells to osteoblast-like cells. So it's bad for the bone. It suppresses the bone turnover, the bone formation, but at the same time, it might be good for the cardiovascular calcification. So the problem comes in with CKD patient. If you give anti-sclerostin antibodies, you can improve the bone formation, but there is always concern about increasing cardiovascular calcification. Here is the biggest study that was published on romosozumab, which is monoclonal antibody against the sclerostin, and they compared it either to placebo or denosumab. And you see patients after receiving the romosozumab, their BMD changed dramatically to the right direction. So it improved the BMD to this patient and also decreased the risk of fracture. So it decreased the risk of fracture. You can see significantly about 1/5. So it decreased the hazard risk of fracture significantly, not only in the hips, but also the total major osteoporotic fracture decreased with romosozumab. But in CKD patient, it's a little bit complicated. So far, we don't use it for CKD patient with GFR less than 60 because we don't have data. And in this study, there was a trend of increased cardiovascular events. We don't know why, but this might be explained by increased cardiovascular calcification risk for this patient. These are some information that we know, and we might need to know more and to dig more. But of course, the problem is not to know, because knowledge is of no value unless you put it in practice. We need to increase our knowledge. Then when we change it and we adopt this knowledge to our practice, we can be more familiar with that. We can increase our, not only our knowledge, but also our understanding about this adynamic bone disease and how to treat our patient. And we can translate this to improvement of our patients' survival and quality of life. And as we know, the great aim of education is not knowledge, but action. So we need to adopt this to action. And hopefully this little information that I shared with you today will improve your practice and also will improve my practice. And I will stop by here for the sake of the time. And if you have any question, I'll be happy to try to answer your questions.
Thank you, Professor Amr. Thank you, Professor Amr, for
Yes,
this
sir.
Thank you very much, Professor Amr, for this highly illustrative and informative, to the point lecture that lasted for about 1 hour regarding this important and hidden topic of nephrology. You highlighted clearly what's adynamic bone disease, what are the causes of adynamic bone disease, and why we should avoid adynamic bone disease, knowing its hazards, and how to diagnose adynamic bone disease apart from bone biopsy, which represents the ghost in adynamic bone disease for many, in generally in bone mineral density for all nephrologists. They think that bone mineral density, we should go to biopsy, but you clearly highlighted the point how to use bone markers in diagnosing adynamic bone disease. And finally, the treatment. What is the treatment? How to treat, basic treatment to avoid, and can we do, and how can and to go to further advanced treatment in this important topic. Thank you very much again. And we are to start discussion. We have one question in the chat, and you have many. Excuse me first to welcome our attending professors, Professor Faisal Shaheen, Professor Ahmed Halawa, Professor Ali Taha, Professor Saeed Khamis, Professor Tariq Tantawi. Welcome everyone, and I will start by, you have one question on the chat. End-stage renal disease patient with low PTH for about 1 year after parathyroidectomy, about around 3 to 4 picogram per liter, and serum calcium around 7 to 8 milligram per deciliter. This patient should stop vitamin D analog or not to avoid adynamic bone disease? And what about the calcium supplements? He's clearly asking about the state of hypocalcemia in low hypoparathyroidism in after parathyroidectomy.
Very good, very good. This is like, a very common question. Every single time I give a talk, I receive a very similar question about post-parathyroidectomy, hypoparathyroid bone disease, and adynamic bone disease. And me and Dr. Halawa has several, meetings and discussion about this common problem after parathyroidectomy. And Dr. Halawa is trying to, teach the surgeon not to be aggressive and to be wise and to be gentle, not to treat, the secondary and tertiary hyperbara because of the end-stage kidney disease as primary hyperbara. Leave our patients with some tissues, some parathyroid tissues. Otherwise, you are going to induce harm more than benefit. So, of course, the lesson and the take-home message is not to do this again, okay? try to be gentle, try to avoid, inducing hypoparathyroidism, because treating hypoparathyroid bone disease in our patient is very, very difficult and it's a challenge. But prevention is much better. Okay, teach your surgeon that you need to keep the BTH above 150. 300, 400 BTH after parathyroidectomy is not a failure. Actually, it's a successful surgery. If the patient has 2,000 or 3,000 BTH level before the surgery, you need to leave the patient with some parathyroid tissue and keep the BTH within the target at least between 200, 300, 400. Okay, don't leave the patient with BTH of, you said, just 2 digits, or less than 10, even 1 digit. That's very bad. The problem comes in, we treat hypocalcemia and hypopara with vitamin D and calcium, right? I just said it. The bone is not active. The bone doesn't take this calcium. And you remember, the calcium in bone is 99% of your calcium goes to the bone. If you don't have active bone and the bone is dead, is not going to utilize this calcium, okay? Then you give a lot of calcium and a lot of vitamin D. I'm very sure you don't see improvement of the serum calcium level. Then you give more and more because you don't have BTH, because the main reason that your calcium stays in the blood is the BTH, right? If you don't have BTH, the calcium doesn't stay in the blood. And where does it go? It goes to the microvascular and macrovascular and induce calcification. And I showed you this study when they did bone biopsy before and after, and they did cardiovascular calcification scores before and after. When you induce, low turnover bone disease, you induce also increased cardiovascular calcification. So you're giving this calcium and you're giving this vitamin D to induce more cardiovascular calcification. So this is a major concern. I don't say that you keep the patient with a calcium level of 5 or 6, then the patient will end up by having a seizure. But you can give the lowest dose, and you don't want to target normal serum calcium level because you don't have normal BTH, okay? If you don't have normal BTH, you wouldn't have normal serum calcium level, because the BTH is the main regulator of the extraserum calcium concentration. So don't over, treat or over correct this hypocalcemia. Then you don't see response. Then you give more and more and induce more harm with increased cardiovascular. Give the minimal dose just to avoid seizures and tetany. Okay, this is number one. And the other thing is there is a room to give a teriparatide or a baloparatide for this patient to, just wake up the bone, to improve the bone formation, to make the bone more active. Then the bone can utilize the calcium. Yes, there is a rule. And, I showed you one study that did a literature review, and there is a lot of other small study that they treated the end-stage kidney disease patients with teriparatide, and the smaller studies with abaloparatide. Yes, we can give that, but keep in mind that hypocalcemia might worsen because the calcium is going to mobilize to the bone. So this can induce more hypocalcemia. So be careful. If you want to give the teriparatide or abaloparatide, watch the serum calcium. You might need to give more serum calcium, and you are not very afraid, when you give the BTH 134, because calcium is going to be mobilized to the bone. So the chance of increasing calcification will be less. So you can be, little bit liberal with the calcium and the vitamin D replacement. If you are giving teriparatide, you can give it for a year. Again, you need to follow up biomarkers, and you need to follow up the serum calcium level.
Okay, I think you clearly illustrated the message not to follow serum calcium and ignoring intact PTH, just keep at the level that prevents seizures and clinical manifestations. Like this?
Yes.
Thank you. Another questions on the chat, and we have nearly doubled one by Professor Ahmed Halawa, and doubled again about how to diagnose and treat post-transplantation Adynamic bone disease. And it was asked by another way, effect of immunosuppression on bone, especially steroids. Let we go with how to prevent adynamic bone disease post-transplantation. Professor Ahmed Halawa. I will leave the mic to Professor Ahmed Halawa later on, but I can answer the question on the chat this time, please.
Very good, very good. So yeah, post-transplant bone disease is another major dilemma.
Yes.
So first of all, steroids. I mean, it's not only steroids. So so let's just go back to the physiology. Secondary and tertiary hyperbara. In secondary hyperbara patients, you usually anticipate, the trigger of the secondary hyperbara is gone after transplantation. But what happened is, with prolonged stimulation of the parathyroid tissue, even before development of tertiary hyperbara, this is going to take time because the gland was, activated for long time. So most of cases, the hyperbara doesn't improve right away. Usually it takes a couple months, up to 6 months. Some studies, some investigators said up to a year, okay? The major problem that can happen is the hypercalcemia in this patient. You can see the BTH is going down. So instead of having BTH of 1,000 or so, BTH goes down to 100 or 200. But the problem is, the calcium level stay high. And there is a lot of reports that this hypercalcemia can induce, tubular injuries and can induce, because of also the polyuria, can induce dehydration and can induce interstitial kidney disease. So you have to be careful. So you have to, first of all, if the patient was taking cinacalcet, or vitamin D analogs, and the BTH was high, don't stop that after the kidney transplantation. You might need just to decrease the dose. Instead of giving, say, 90 milligram of Sensibar, you might need to give 30 milligram or so. So you need to follow. Don't anticipate that if you have severe secondary hyperbara or tertiary hyperbara, this is going to resolve right after the transplant. It takes time, and you have to watch, and sometimes you have to intervene, and you might need to keep the vitamin D analogs or the calcium mimetics if needed, because this takes time. The problem with post-transplant bone disease is not only hyperbara, but also the steroid, which is very well-known cause of inducing secondary osteoporosis and increasing the risk of fracture. First of all, at the beginning, in the first 14 days or so after transplantation, giving a lot of IV steroids and big dose of oral steroids increase the bone resorption. So the bone loss will be very high at the beginning, but with the long-term use of small dose of steroid, actually it induces low turnover bone disease. So there's two phases. The first phase is significant swift and quick bone loss because of increased bone resorption. Then the long-term use of steroid induce actually suppression of bone formation and induce low turnover bone disease. So, minimizing steroid is a key here. If you can use a steroid-free protocol, this would improve the bone health and will prevent the post-transplant bone loss. However, other immunosuppressive agents, especially calcineurin inhibitor, sirolimus, everolimus, also has a negative impact on the bone. Maybe CellCept, the anti-proliferative agent, has the least effect on bone, and steroids has the worst impact on bone, but also calcineurin inhibitor and sirolimus, everolimus, rapamycin has a negative impact on bone. So we have to be vigilant. Sometimes we have actually to give anti-osteoporotic medication for this patient. You can follow the marker, you can do BMD after the time of transplantation and every year or so, and you can treat your patient. If you see there is some loss of the BMD, you can treat. If you you think this patient has low or Adynamic bone disease, you can give Osteoanabolic. If the patient has high tendency for high turnover bone disease, you can give anti-osteoporotic medication, anti-resorptive therapies. Sometimes the patient will need also bone biopsy to be certain what's going on. So the bone, the disease doesn't resolve completely after improvement of the kidney function, because there is a lot of contributors and co-players in this area. And the bottom line is you need to follow this patient up and to intervene whenever needed.
Thank you very much. Another question. Is it better to do partial thyroidectomy or complete parathyroidectomy with transplantation of part of parathyroid gland subcutaneous?
Very good question. I will leave this to Dr. Halawa, but my take-home message is doesn't matter. Total versus subtotal, auto transplantation versus no transplantation. This is not the key. The key is to be gentle, but Dr. Halawa can give us more feedback about that.
Okay, another one. Does osteoanabolic agents have any benefit after occurrence of low-bone turnover with symptoms such as fracture, or they used for prevention in early stages in asymptomatic state?
Both in prevention and treatment. Actually, we use it more in treatment rather than prevention.
Okay, thank you. Patient with CKD stage 4 with a normal phosphorus and serum calcium and PTH 30. Can we start teriparatide?
So first of all, we did a CKD study when we did bone biopsy for CKD patient at different stages, and we find that low turnover bone disease is usually prevalent in early stages. Then high turnover bone disease usually happen in late stage 4 or stage 5. So low turnover bone disease, yes, happens. It can be actually an adaptive mechanism or compensatory mechanism to prevent the high turnover bone disease. So if you have a PTH of 30, if you have normal serum calcium, as you said, and normal serum phosphorus, and if the patient is asymptomatic, do the BMD, do DIXA scan. If the patient doesn't have osteoporosis, you don't have to do anything. Just keep following and checking on the biomarker as recommended by the KDIGO guidelines. Then you don't intervene. You don't treat asymptomatic patients just for a PTH of 30. PTH of 30 for non-dialysis patient, if you have serum calcium, normal serum calcium level, normal serum phosphorus level, if you have normal fracture excretion of phosphorus, and if you have normal BMD, you don't have to treat it. But if the patient has bone loss, has osteoporotic fracture, has low BMD, this is another thing you need to intervene and you need to treat. Then you need to understand if the patient have low or high turnover bone disease. Most likely in this stage 4, which is advanced CKD, you would anticipate that the patient will have low turnover bone disease if the PTH is 30, but you can do also some other biomarker to make sure that the patient certainly have Adynamic bone disease if you want to treat it with the Osteoanabolics.
Another questions maybe somewhat away from the lecture, but in the same scope. He has asked about your experience, the role of Borrelia denosumab in treating osteoporosis in dialysis patients. What are the precautions and contraindications?
Very good, very good.
Dr. Ahmed asks about your experience, Dr. Ahmed Bahnasi.
You're asking me, right?
Yes.
Okay,
yes.
Very good. Yeah, this is another talk. We just focused today on Adynamic bone disease, but if the patient has high turnover bone disease, you can treat the high turnover bone disease by cinacalcid, vitamin D analogs. And if the patient still have bone loss after controlling the PTH, you can use anti-resorptive therapy and anti-osteoporotic therapies like bisphosphonates or denosumab. Both should work. But again, the major side effects of denosumab is the hypocalcemia in dialysis patient. So you have to be following the serum calcium level, every 2 weeks, initially every week, then every 2 weeks. You have to make sure that the patient is not developing serious hypocalcemia, as this was reported in several studies. The problem with the denosumab, specific with denosumab, denosumab is very good rank L monoclonal antibody, inhibitor. So it will decrease the bone resorption. But the problem with the denosumab, after stopping the therapy, most of the study showed that the biomarker will be rebounding. So the bone formation rate and bone resorption rate will be very high after stopping the medication, and this might increase the chance of having more fracture. So you have to be also very careful, because you're not going to give denosumab forever. You give every 6 months for a year or two, but of the medicine, you might have increased chance of fracture. By the time some bone experts, they alternate between osteoanabolic and denosumab, or osteoanabolic and bisphosphonates accordingly. But of therapy, you have also to follow the patient. Don't just say, I treated the patient for a year or two, then you do nothing, because you might actually increase the chance of fracture after stopping the therapy.
Thank you. Coming to welcome our attending professors, Professor Ahmed Halawa, welcome.
Hi, Professor Yasser. Thank you, Professor Am, for this elegant lecture and the nice debate about parathyroidectomy versus Calcet.
Medical and surgical debate.
This is a lifelong debate.
Yes. Who treat?
No, but I totally agree with Prof. Am. It is one of my nightmares is to turn the patient from hyperparathyroidism to adynamic bone disease. You made the patient worse. So, in my opinion, because as Professor Am mentioned, there is mortality associated with adynamic bone disease. The calcification, actually, vessels will get calcified, valves, a heart valve will get calcified with adynamic bone disease, because we lost the buffering action of the bone because of the absence or near absence of PTH. But the problem surgically is not that easy to just, advise the surgeon just to be gentle, because the surgeon is stuck between the devil and deep water. So if he removes too much of parathyroid tissue, will end up by adynamic bone disease. If he left some parathyroid tissues, especially in CKD patients, there's still continuous stimulation. So basically they will get recurrence. And this neck is one of the difficult operations you will ever do when you dive in a redo operation. I will remind you, the neck is a very tight compartment full of important viscera, esophagus, trachea, nerves, everything. And also scar tissue is quite difficult to deal with in the neck, because if any damage happened, it will be it will end up by permanent disability. But the best way is to prevent the disease from going to the from being referred to the surgeon. So prevent the CKD MBD in the first place, because parathyroidectomy, as you can tell, is not curative. You will never get it right to get the PTH above 300. I wouldn't blame the surgeon if he tried his best to leave parathyroid tissue and have the understanding that leaving parathyroid tissues behind will help the patient, rather than treating his sick ego of just showing off that I have removed 5 parathyroids, 6 parathyroids. This is not quite right. But we come to the situation where there's, normally we have 4 parathyroid glands, but in CKD patients, it could be more than that. I remove up to 7. What should I do if I found plenty of parathyroids in the neck? If I lift something, will end up by recurrence. If I removed everything, and this is what I would normally do in more than 4 parathyroid glands, because I'm always frightened and scared to death that I'm leaving another gland which I couldn't find, in the chest, or arch of the aorta, even on the heart itself. So it is sometimes inevitable that you leave, you take all parathyroid glands. What about if we found 3? in many occasions, we have only 3 glands. I will never know unless I remove the 3 and then I'll find the PTH is 2. So it's not an easy situation. Parathyroidectomy, as I mentioned, is not curative. The patient shouldn't reach this stage, and CKD MBD should be prevented in the first place before getting the surgeon's knife into the neck. But I think the surgeons, and hope that, many surgeons, I don't think that many surgeons attending this lecture to take the wisdom that they're doing too much harm if they're taking all parathyroids out. Prevention better than cure. The second question is, Professor Ram, teriparatide, we give it for life, is it right?
We give it for a maximum of 2 years because of the FDA approved it only for 2 years here in America. In Europe, they approved it for 3 years, so not more than 2 or 3 years in Europe, if you would, because of there is some experimental, animal study that showed teriparatide for longer time, you can induce osteogenic sarcoma.
So again, teriparatide is not the answer because it's quite expensive drug as well. In addition to you cannot give it more than 3 years because the theoretical risk of osteosarcoma, which has been found in rat. So again, the teriparatide and its counterpart is not the answer as well. So the answer is try not to reach the stage of adynamic bone disease. So to be honest, I don't know, and I'll be delighted that in my parathyroidectomy case will be canceled on the day, because at least I won't blame myself of inducing harm, which I have sometimes to do it that way. But the intention should be leaving parathyroid tissues behind. The message for all surgeons to be aware of adynamic bone disease is a fatal disease. And that's it really. And thank you for this wonderful lecture.
Thank you, sir.
Thank you. We have a question on the chat. I think he's reading Professor Halawa thoughts. He's saying, if you have a patient with prolonged tertiary hyperpara and all glands are enlarged, and you have high risk of adynamic bone disease and transplantation, would you insist to take the risk or keep the patient with hyperparathyroidism?
No, we take the risk. Of course.
You take the risk.
Yeah, because these patients won't respond to medical treatment. If they have the big glands, we remove glands. It's orange size, or just lemon size, big glands.
Yeah.
Just
big like that.
Yeah, it won't be. I showed you, the images last time. It's difficult to treat them medically. They won't respond. And actually, my physician colleagues tried to treat it medically, and this is why they're being referred to us. And this is the patient will end up by adynamic bone disease because you remove all pathological glands. Also, when you leave parathyroid tissues behind, you didn't know how much parathyroid tissues in the bit you left. It could be scar tissue, could be calcified tissue, could be area of hemorrhage and necrosis, and you think it's parathyroid tissues. No, but even normal parathyroid gland is 50% of the normal parathyroid gland full of fat. So again, the judgment, how much you should leave to ensure PTH of 300, it's quite difficult.
Thank you. Professor Faisal Shaheen, welcome, Professor Faisal.
Thank you, Professor Yasser, and I enjoy, as usual, the talk from Amr. He's so excellent, actually. He got the difficult, make it really difficult lectures, make it very easy for us to understand. And I have only one comment about the dialysate content calcium. Is it, you don't mention anything about this. What do you think? Should we make it higher or lower, or especially post-operative if we have hyperparathyroidectomy and then severe hypocalcemia? Is this play any roles to change the calcium content of the dialysate? This is one. The second is teriparatide is known that it decreases the hospitalization by around 20%. And I think you answered that question that we could use it for up to 3 years. Can we use it as only, some injection just immediately post-operative and then we'll stop it or not? Thank you.
Thank you so much. First of all, about the calcium dialysate calcium, the KDIGO guideline still recommend 2.5 to 3 milliequivalent per liter of calcium dialysate and the hemodialysis. Of course, the BD has more than that, usually 3.25 to 3.5. If you ask me my opinion, I would like to go down on this, but we still follow the KDIGO guidelines. I think 2.25 milliequivalent should be enough and should help not to put our patient on a positive calcium balance. The risk of having low serum calcium and hypocalcemia and its consequences is very low in our patients, as we know, because of the little bit acidosis that our patients have. We don't usually see seizures or hyperexcitability of for our neuromuscular system in our patient. Very rare to see that. I would like to go down, but I still follow the KDIGO guidelines. Of course, lower dialysate calcium would improve the bone formation and the bone turnover, and will not put the patient on a positive calcium balance that increase cardiovascular calcification. But I think we need more studies on that. And till this point, we just need to follow the KDIGO guidelines. The second question about giving short-term teriparatide, you can. It stimulates the bone. You still have biomarker you need to follow, okay? So if you give, I don't know, for a couple of weeks or a couple of months or something like that, usually bone formation rate is slow. Usually it takes at least 3 to 4 months, up to 6 months to see improvement on bone formation biomarker. Bone resorption is quicker. You can see the effect in a month or two. The biomarker, the bone resorption marker, will improve quicker. But at least, I don't think giving the BTH, the teriparatide or palaparatide for a couple of weeks or a month would do any significant difference. But maybe at least 6 months or something like that, then you follow the biomarker and see if there is significant improvement. You can hold it and see the response.
Thank you.
Yes, sir.
Professor Saeed Khamis, welcome.
Thank you, Professor Yasser. Thank you, Professor Amr.
We missed you last time, last session.
It's too late for him. He was in bed.
For this presentation as usual. Just I have 2 questions regarding the dynamic bone disease. For sure, low pH is there. Low BTH is there. What about the relation between the low BTH and the immune system? I mean, is there any immune dysfunction with this low BTH? And if yes, what is the mechanism or the pathogenesis? Second is the role of spinal microbiota in the pathogenesis and the possible treatment of CKD MBD. And thank you so much.
Thank you so much. 2 hard questions. The relationship between BTH and the immune system. Yes, there is some low evidence relationship between BTH and the immune system. And actually this comes in because they found after doing parathyroidectomy, after transplantation, might actually increase the risk of acute rejection. And they said the BTH might have immunosuppressive effect, and taking out the parathyroid tissue might enhance or trigger the immune system to induce rejection. However, the evidence is very low. It's a case reports. So it's not very good evidence. The microbiota and its impact on bone, I don't have solid evidence also about that. Microbiota actually can help to clear uremic toxins, usually with low molecular weight uremic toxins, but high molecular weight toxins, especially when it comes to BTH, is tough. It might help to decrease the phosphate absorption in the gut. So it might help the hyperphosphatemia. Again, the evidence behind this is very, very low. So I cannot comment. There is no, even if they target some biomarkers, they don't target at least, bone mineral density by DEXA or bone biopsy or hard outcomes. They just target soft outcomes as uremic toxins and calcium and phosphates, which is, you can anticipate that there will be some improvement in these, but would this be translated to improvement bone health? I have no evidence about that.
Thank you, sir.
We have another question in the chat. To leave patient with hyperparathyroidism is better than having a dynamic bone disease post-transplant. Is this statement wise?
So hyperparathyroidism is adaptive. It's a compensatory. If you don't have hyperparathyroidism for end-stage kidney disease patients, you usually have low or adynamic bone disease. So mild hyperbara is healthy, is adaptive, is a compensatory mechanism. I don't have problem with that. Moderate hyperbara, having BTH of 300, 400, might be okay. Look to other biomarker, make sure that patient doesn't have high turnover bone disease. But of course, severe hyperbara is bad. So the balance, modesty is the key. We don't like to see extreme, either very low or very high. Something in between, even mild or moderate hyperbara should be fine. Even mild, when we talk about low turnover bone disease, even mild is different from moderate or severe. If you leave the patient with BTH of 150 or 200, it's different from leaving the BTH with 10 or 20, okay? So there is a range, of a very big range, and there is a gray zone. It's not black and white. So we just need to keep the patient and, in the middle, not in the extreme. So modesty is the key here.
Yes. And we have no more questions in the chat. And excuse me to get this chance of having you today and ask some questions. Do you agree that bony pains, one of the most important causes of bony pains is adynamic bone disease, or not?
Yeah, adynamic bone disease can induce bone pain, but actually high turnover bone disease can induce more pain because of increased bone resorption. So, if you are comparing high to low turnover bone disease is usually asymptomatic. You wouldn't see a lot of bone pains, but actually bone pain might be a manifestation of high turnover bone disease, cyst fibrosis cystica, and others rather than the low turnover bone disease.
So if we have bony pains in a state of low PTH or within normal, we have to think of osteomalacia more than adynamic bone disease.
Hyperparathyroid bone disease. Osteomalacia usually also is
with normal
asymptomatic, but there is other causes of bone pain. High turnover bone disease is one of the most important. Oxalate deposition in the bone also is important. We have patients with severe bone pain because of oxalate, in patient with hyperoxaluria type 1 or type 2. But adynamic bone disease is not a common cause of bone pain.
Okay. Regarding CKD not on dialysis, the same criteria of adynamic bone disease, including the level of PTH and targets of treatment and targets of bony markers? Or
so we mentioned in early stage of CKD, low turnover bone disease is very prevalent. I think in our study, we have about 75% of patients with low turnover bone disease with early stages of CKD. Again, it depends on, if it is mild, it's just a compensatory or adaptive mechanism, shouldn't be a problem. The problem if you have a very, very low BTH level, if you have patient is losing their bone, you do BMD and the patient have severe osteoporosis, or at least a rapid loss of BMD, you can follow every year or so. If you have the biomarker, if you see the bone-specific alkaline phosphatase or even the alkaline phosphatase is very low, the bone resorption markers, the thyroid-resistant acid phosphatase or CTX is very low. This might indicate that this patient might need some intervention. Make sure that don't give calcium, don't give a lot of vitamin D for this patient, and of course, don't give these patients calcium mimetics.
Okay. Do you target normal PTH in CKD patients in treating hyperparathyroidism or not at all?
What is normal? The definition of normal is different here. So in patient with CKD stage, say 4 and 5, prior to dialysis, having BTH, you look, of course, to the trend, and you don't look only to the BTH, but you look also for the calcium and phosphorus and other biomarkers. So having a BTH, up to, the normal is up to 60 or 70. So in CKD, if you have up to 150 or so with normal serum calcium and phosphorus, this means that this is an adaptive to, compensate to avoid hyperphosphatemia, because you anticipate that FGF23 goes up, and this will try to prevent hyperphosphatemia. And also BTH is a phosphatory hormone. So secondary hyperbara happens just to control the serum phosphorus level and to avoid having the patient on a positive phosphorus balance. So mild hyperbara should happen to avoid little overbone disease. Don't oversuppress it. Keep the BTH, in advanced CKD around 100, 150. Look to the trend more than the absolute number, and look also to other, biomarker, serum calcium, serum phosphorus, fraction excretion of phosphorus, bone-specific alkaline phosphatase, bone formation marker, and bone resorption marker.
Thank you. I have 2 more questions. How many times it take to reverse adynamic bone disease using usual measures of decreasing vitamin D analogs and such?
How many times?
Sorry, I'm sorry. What's the time to take?
Time? Oh yeah, give it at least 6 months.
Yeah,
the bone turnover cycles usually take at least 3 to 4 months. And if the patient has adynamic bone disease, this means that the turnover is low, the bone remodeling cycle is slow. So at least give it 6 months. I wouldn't do any intervention, any advanced intervention, but just basic intervention for 6 months. If the patient doesn't respond, then I repeat the BMD, I repeat biomarker. If there is no significant, change, I would move from the basic to the advanced intervention.
My last question is you said that the use of teriparatide instead of adynamic low PTH and hypercalcemia, right?
Right.
With no effect on the serum calcium level, no effect on serum calcium level?
Very, very good question. So BTH, we know that still the teriparatide is 134 BTH. It can actually induce hypercalcemia, right? But it depends on what does it do. If it improves the bone formation, if the bone was dead or very hypoactive and now it's active, so you would anticipate that the calcium will mobilize, will move to the bone. So you would actually anticipate hypocalcemia. So it depends. If you give a BTH and you don't have, it depends on the response. If it dramatically improves the bone formation very quick, you would anticipate hypocalcemia. If it doesn't, and the bone formation doesn't wake up and the bone formation stay on the lower side, actually it can induce hypercalcemia. So the serum calcium level is one of the integral component that you need to follow if you are giving teriparatide, because you can get, it's bidirectional, can go, to the higher side or lower side. So again, you have to be vigilant and you have to check the serum calcium level, not to induce hypercalcemia or hypocalcemia if the bone formation rate improves very fast.
Thank you very much. I have no more questions, and we have no more questions on the chat. I think we have one question. Just 1 minute. need to understand the hypocalcemia corrected by low calcium dialysate alone without vitamin D post parathyroidectomy, hypoparathyroidism. I think it's not clear. Okay. Thank you, Professor Amr, for this
Thank you,
highly
Dr.
elegant
Yasser,
lecture. And thank you
thanks
all,
for everyone. I think it's a very thoughtful discussion today. I really enjoyed it.
Yes, we enjoyed the discussion and the lecture on more than each other.
Thank you so much, and hopefully we can meet in the future in other, spectrum of renal dystrophy as well.
Thank you so much, and thank you all our attending professors and our all attending physicians. And excuse me to close this session. And welcome to see you in the next session by the coming Wednesday, resistant hypertension, which will be by Professor Saeed Khamis next Wednesday at 9 p.m. our usual date. Thank you all, and have a good night. Thank you.
You too. Thank you.
Thank you.
Thank you.